So my task is to try to really impress the impact that drug interactions can have and the way that we can manage those drug interactions. So I showed you yesterday that one of the key features of both the telaprevir and boceprevir is the fact that they inhibit one of the key enzymes in the liver which metabolizes a lot of the drugs that a patient may be taking. And that inhibition can cause drug interactions, and we have to think about how do we manage those drug interactions. That's not the only mechanism, as I tried to indicate in my talk yesterday, but I think that is the one that we really are concerned about. Cytochrome P453A metabolizes around 40 or so % of all the drugs that patients may be taking. And so we have to think about that. What is the effect of introducing another drug into a patient's regimen? So here what I've tried to illustrate is that we may have a patient who is stabilized on a therapy. That is, we give the dose of the drug is absorbed, and the patient is stabilized because the drug concentration is achieving the effect. Now we introduce a drug which begins to inhibit the way that the drug is being cleared from the body, and the drug concentrations increase, and that can lead to drug toxicity. There is another example where the patient is stabilized on therapy, and we're happy with the way the patient is being managed, but the drug causes a decrease in the concentrations of the drug, and that can potentially lead to a loss of efficacy. So these are the two ways that drug interactions, either to cause toxicity or to cause a loss of efficacy, those are the two mechanisms that we are really concerned about. So we've already seen this patient, and I want to concentrate on the drugs that the patient was taking prior to considering the use of a DAA. So this is the 54-year-old male, genotype, fibrosis stage, but the patient has got type 2 diabetes and is taking metformin. The patient has got a high cardiovascular risk and is taking a statin, has hypertension and is taking a beta blocker, is suffering from mild depression and at this stage is receiving behavioral therapy, and is using sildenafil Viagra for erectile dysfunction. So the consideration is which DAA, and the decision is to go with the shorter course therapy of telaprevir. And then we have to say which medications that the patient was taking would be a concern now you are starting with telaprevir. So metformin, that is not a consideration leading to a major problem, because this drug undergoes renal excretion, and so no interaction would be expected. And in most of the presentation, I'm going to use green as being no interaction, meaning go. That is not a problem. We can go. Propranolol, we can go. That is not an issue because it's metabolized by a non-CYP3A pathway in the liver. It's metabolized by a different enzyme. But sildenafil Viagra is potentially more of a problem. It is not recommended, although some patients will not take too much notice if they decide they're feeling well enough and they want to continue taking sildenafil. The recommendation is to go to a drug, tadalafil, for the treatment of erectile dysfunction, which is less in terms of interacting, although you would still have to monitor the dose, the way that the drug is being used, with a dose decrease. But the statin, atorvastatin, was what the patient was taking, and we actually have data to show an increase in the atorvastatin exposure with telaprevir of around 8-fold, 800% increase in atorvastatin. And so atorvastatin is contraindicated, as is simvastatin. That is also contraindicated because of the magnitude of the interaction. There are some statins which are less interacting and would require close monitoring or a change of the way the drug is being used, but it's less of an interaction potential. However, many clinicians will consider that the risk is not great enough to continue with the statin, and you could stop the statin for 12 weeks. Now, that is clearly an individual patient management decision, and that is something that would need to be discussed, and this is in consultation with the cardiologist, that the statin could be temporarily stopped because of the magnitude of the interaction. So summarizing those interactions, one drug is stopped, that is the atorvastatin. No changes for metformin or propranolol. Sildenafil has been replaced with tadalafil. So you've already seen the way that the hemoglobin was declining. I want to focus on the development of the mild rash and the fact that the depression worsened and becomes moderate in severity. So how would you manage the patient's mild rash? Would you give systemic steroids, topical corticosteroids, and maybe also systemic antihistamines? Would you discontinue telaprevir or not treat the rash? And the answer in this case is number 2, that we would go for the topical corticosteroids and also consider systemic antihistamines. You do not use systemic corticosteroids. Not recommended because of the magnitude of the interaction effect due to cytochrome P453A. Significant increases would be anticipated. And also, in fact, one of those steroids, dexamethasone, could reduce the levels of telaprevir by a mechanism of enzyme induction. However, the topically applied steroids in this designation are green to go because the magnitude of any interaction is going to be very small because this is topical administration. And only a small percentage may actually reach the systemic circulation. So it's okay, not expected to cause any effect. What about using, if we decide an antihistamine? Well, there are a number of antihistamines that we can use, which are green in my designation. Chlorpheniramine, desloratadine, levocetirizine, promethazine. All of these drugs are safe to use, no interaction would be expected. So in terms of management, we can manage the rash situation by the use of topical steroids and emollients as well, in terms of giving the emollient to the skin, and that is a way to manage. So in this patient, a topical betamethasone is initiated, and also desloratadine as an antihistamine. So again, the treatment decision is to think about the way we manage. However, the patient's depression is now worsening, and the consideration is to give an antidepressant. And there are clearly a number of options of antidepressants. Here are just a few. And there is no right answer. So here we're not saying there is a right answer. There is only one antidepressant. We have to consider a number of issues. Those issues are really that there are antidepressants which are metabolized by that enzyme and where an interaction is likely and may make management more difficult, and management considerations are then the dose. Whereas there are antidepressants which are not metabolized by cytochrome P453A, and an interaction is unlikely. So what we need to think about is there are some interactions potentially with antidepressants, and some antidepressants are unlikely to interact, and therefore there are options for us to consider. But notice now another unlucky episode happens. The patient is doing well from a virologic perspective, but the patient breaks his leg at week 8 and appears in the emergency unit, and you're asked for advice about the potential now for using some other medications. So the internist wants to administer midazolam intravenously and morphine. So now the recommendation is, well, we need to consider what are the issues. Is an interaction with morphine unlikely, or morphine exposure may be increased? Interaction with midazolam is unlikely, or midazolam exposure may be increased. Actually, there are two things that might happen, and we come under designation A. An interaction with morphine is unlikely, but midazolam exposure may be increased. So A and D are the considerations here. So morphine, based on the way the drug is handling morphine, an interaction is not expected. But with intravenous midazolam, we have to consider that an interaction will be anticipated, and co-administration should be done in the setting of monitoring and appropriate management of that patient. And so one interaction could be expected, another not expected. And back home, the patient is prescribed something far simpler. So this is the patient. Quite complex in terms of the number of different drugs, but management issues can be something that we have to proceed with and can be done. And that is clearly important. So here, during the 12 weeks of telaprevir, you have the considerations for these drugs. We now restart the statin, the rash disappeared, the steroid is stopped, and depression symptoms improve. Now, just a couple of other considerations. Number one, and this is separate from the patient, this patient, just to consider the issues around transplantation, which came up in a question yesterday. So I said yesterday, and just to reinforce that issue, that with the two major immunosuppressants, cyclosporin A and tacrolimus, with telaprevir, we see a 5-fold increase in cyclosporin exposure and a 70-fold increase in tacrolimus exposure. And therefore, significant dose reductions of the immunosuppressants will be necessary in conjunction with telaprevir and monitoring of immunosuppressant blood levels. With boceprevir, interactions are also expected, and we see with cyclosporin about a 3-fold increase in exposure, with tacrolimus a 17-fold increase in exposure. So with both DAAs, there are interactions with the immunosuppressants. Now here is a case from a friend, Xavier Fauns, who treated a patient who was on tacrolimus stabilized with telaprevir. The dose of tacrolimus was 2 milligrams per day. The patient started telaprevir, and the dose of the tacrolimus was reduced to around 0.2 milligrams every 2 or 3 days. So the dose is now down here. And the monitoring of the plasma levels of the immunosuppressant is being done to maintain adequate tacrolimus concentrations. At the end of the 12-week period, then the dose has to be increased, and in fact slightly increased back to 3 milligrams per day with a rebound effect. So this is management of a highly, in a sense, a difficult drug interaction, but in a specialist setting, then that interaction can be managed. And overall, we now have data from a number of studies, and this is with tacrolimus, sirolimus, cyclosporin, in 9 patients, the kind of daily dose at baseline, and then the average daily dose during triple therapy, and this is the dose reduction. 20-fold, 7-fold, and 2.5-fold in those patients. So we need a stepwise management plan. Number one is to note the co-medications. I cannot stress that enough. You need to know the co-medications. So we need to note all of the co-medications the patient is on, including any herbal products or any other products the patient may be taking. Then consult. In some countries you can consult a pharmacist, and maybe that's not always possible, but there are online resources. Consider temporary interruption with some medications, that may be possible, or an alternative medication. And then many medications can be managed by dose adjustment. So it's a consideration of all of those issues with the concomitant drugs the patient is taking. My final comment is, what about drugs of abuse or legal highs, which we have in some countries? So drugs of abuse such as heroin, dihydrocodeine, cannabis, cocaine, amphetamine, methamphetamine, all of these drugs in different countries, there may be different considerations, but in my country, these are the kind of drugs that we sometimes get asked about. Of course, you're never going to have any study data. You don't do studies with these sort of drug interactions, so we don't actually have study data. So we have to make some guesses or expert opinion as to whether a drug interaction may be likely. We look at the way the drug is handled by the liver, and then we say, is the effect of the DAA likely to increase the concentrations? Yes, dihydrocodeine. Yes, cannabis. No, cocaine. I'm actually not sure about amphetamine because the data concerning how that drug is handled is not clear. Ketamine, yes, likely to increase. And so we try to get some estimation of whether those drugs will be more of a problem under telaprevir or boceprevir administration. Now my final slide, or a couple of slides, are to say we're beginning to get data of which drugs are being used in patients with chronic hepatitis C. This is a US database, so this is a US claims database. And these are the drugs being used in patients with the highest incidence of use. So there are analgesics, steroids, antidepressants, for example, cardiac drugs. So you can see some of the drugs that I've been talking about are in this list. And virtually all of the drugs are now present in the database that we manage and in some of the reviews. And this is a review that's been published recently about clinical management of drug-drug interactions in HCV therapy, some of the challenges and some of the solutions. So we try to include all of these drugs in our database, and you can summarize and get the summary of the interaction on an iPhone or an Android or an iPad. And we are now considering translating the websites into different languages such as Spanish, and also a consideration for translating the website into Russian. But if anyone has any comments about drugs that should be included, then we would be delighted to know so that we can improve it.